My name is Erin Peacock. I'm an assistant professor at the Tulane University School of Medicine, and I'm pleased to have the opportunity to present preliminary work from my BIRCH project entitled Implementation of Sleep Health Promotion Strategies that Address Sex-Specific Factors in Federally Qualified Health Centers. So we know that insomnia is the most prevalent sleep disorder and is associated with cardiometabolic outcomes. We also know that women are twice as likely to experience sleep disruptions and insomnia throughout their lifespan compared to men. Cognitive behavioral therapy for insomnia, or CBTI, is a highly efficacious and fast-acting intervention that's associated with robust improvements in sleep. Yet this evidence-based intervention is severely underutilized in clinic and community settings. The focus of this part of my BIRCH project is on understanding how CBTI can be implemented in low-resource primary care settings. And in this poster, I'll be focusing on the feasibility and acceptability of collecting objective sleep data among healthcare workers who will be the eventual implementers of a CBTI intervention. I'll also examine associations between sleep and cardiovascular metrics. We recruited 80 healthcare workers from 9 partnering FQHCs in Louisiana. Participants wore a BioStrap wrist-worn sensor 24 hours a day for 6 weeks. The BioStrap records sleep onset and wake, as well as heart rate and heart rate variability, among other metrics. Heart rate variability is the beat-to-beat variance in heart rate, and it generally measures a person's physiologic capacity to respond to stress, with higher indicating better response to stress. Heart rate is measured as beats per minute, and in this case, higher means less efficient heart function or lower cardiovascular fitness. We used all sleep and heart data recorded in the 14-day period following the first night of sleep data, and we excluded those with fewer than 4 nights of data. We used mixed effects models to estimate associations between sleep and cardiovascular metrics. Figure 1 shows enrollment and retention information for this sample. 74 of the 78 retained participants, or 95%, were able to set up the device and record sleep data. In figure 2, you can see that 80% of participants were able to record at least 10 nights of sleep data in the 14-day period. The remaining results are presented for the 68 participants with at least 4 nights of sleep data recorded. Participant characteristics are presented in Table 1. The average age of the sample was 45 years old, 93% were women, and 38% self-identified as Black. The forest plots in figure 4 show the adjusted associations between sleep and heart rate on the left, heart rate variability on the right. For heart rate on the left, the sleep indicators for which higher equals worse sleep are consistently associated with higher or worse heart rate, while the opposite is true for sleep indicators for which higher equals better sleep. For heart rate variability on the right, the sleep indicators for which higher equals better sleep are associated with higher or better heart rate variability, while the opposite is true for sleep indicators for which higher equals worse sleep. However, only the associations with sleep efficiency, insufficient sleep, and wake after sleep onset are statistically significant. Finally, figure 4 presents data on the acceptability. There was high agreement with nearly every statement presented here, reflecting high acceptability. Interestingly, nearly 80% agreed that it would be beneficial for their patients to wear a device similar to the BioStrap, which is a promising finding among these eventual implementers of a sleep health intervention in primary care. So in this sample of mostly female FQHC healthcare workers, objective sleep measurement was both feasible and acceptable, and sleep health was associated with better cardiovascular health, including heart rate variability and heart rate. Further research is currently underway to determine sex-specific barriers and facilitators to the adoption and uptake of CBTI in low-resource primary care settings as a means to improve cardiovascular health and reduce disparities. Thank you.